Facebook. Okay, so we are live. Good morning, everyone. Welcome to our weekly session for CMAAO. The topic for today is sepsis management in India, what we learned in last 25 years. We are meeting of 8th of February 2025. If anybody wish to join this meeting, I would like to open this for public. They can join Zoom at 8188591157. I repeat, 8188591157. To talk about this topic, we have our distinguished guest, Dr. Yatin Mehta. He's joining in from Delhi, Haryana. He's a chairman for Institute of Critical Care and Anesthesia from Medanta, the Medicity, Gurgaon, one of the very prestigious hospital. He has over 40 years of experience as a distinguished expert in anesthesiology and critical care. He's a past president of SWAAC ELSO. He's a president for Simulation Society India. He's a teacher for DNB and FNB for the last 20 years. He has more than 56 chapters in books, 390 publications, and approximately 650 presentations and conferences. He is author of 6 guidelines, has edited several books in critical care, textbooks, atlas, NCQs, pocket books for critical care, preventions of healthcare associated infections, MCQs and infections, disease for textbooks of critical care, and has many international publications in ICU sepsis. He has several awards for his contribution in the field, to this field. Medical Doctor for the year 2010, Vashit Chikitsa Ratan Award in 2012, Dronacharya Award in 2019, the Guardian of Health Award in 2021, Honorary Distinguished Fellow in 2023, and many other honors in his name. His area of interest is critical care medicine and cardiac anesthesia. Sir, over to you. We are pleased to have you here.
Thank you, Saurabh, for a kind introduction, and indeed a pleasure to be here, and also to meet my friends from all over the world. I think sepsis is a problem which affects all of us, particularly more so in the developing countries, and bacteria has no borders. So I think this topic is relevant to everyone concerned. And now why next half an hour or so, I'm going to talk about what are the things which have changed over the last few years and what has changed in India, which is relevant to the neighboring countries also. So it's a huge problem. Most of the time in public domain, you talk about myocardial infarction, strokes, cancer, trauma, but sepsis is going to kill more patients than all these things put together by year 2050. So you get about 50 million patients per year at the moment, out of which 1/4 will die. And I think the mortality has remained high over the years, despite advances in critical care, advances in sepsis management, newer antibiotics, and so on. For people who are interested in sepsis particularly, this is a very complex issue. The pro-inflammatory cytokines release their patient's own neutrophils and mast cells and monocytes and macrophages and dendritic cells get activated. So activated cells produce either pro-inflammatory cytokines or anti-inflammatory cytokines, and either depending on the balance of the two will be decided which way the patient is heading. There are microcirculatory issues, there are microthrombi which are found, and so on. So it is not the bug which itself kills directly the patient, it is body's own response which tilts the balance the wrong way. So as again, recuperating what I have been saying, coagulopathy, microcirculatory shock is a problem, perfusion, endothelial dysfunction, and glycocalyx getting affected is a serious problem. Because of that, there is vasoplegia, interstitial edema, there is metabolic derangement, lactacidosis, finally immunoparalysis, apoptosis, and death. So what has happened over the last century or so, more than a century, beginning from 1860 of Louis Pasteur's germ theory. Then Robert Koch postulates the causative organism, 1890. Then finally, you came in 2004. Sorry, 2001. Rivers talked about early goal-directed therapy in septic shock, and Philip Dellinger talked about in 2004 the Surviving Sepsis campaign began, and the goal was to reduce the mortality of sepsis substantially. Then in 2008, you had the Corticus trial, demonstrated the utility of steroids. TRIS trial from Canada about blood transfusion and platelet transfusion and so on. And then you had the Process, Promise, and Arise studies from different parts of the world. I'll talk about that a bit later. But they were all guiding the fluid therapy in sepsis and septic shock. And 2000 sepsis, you had the sepsis 3 definition, 16. It was redefined. And then the guidelines came finally. So these were the 2021 guideline committee from all over the world. These were the top leaders of the world. This is Linda Evans, Andy Rhodes, and this is from Italy, and this is me there representing India. So let's see what were the changes which were suggested by this group, which was published. So regarding beginning from screening, the patient arrives in the hospital, machine learning tools were recommended, and QSOFA as a screening tool can be used in the emergency, but not in the floors. Regarding the initial resuscitation, we recommended within 3 hours administration of 30 mils per kilo, which is flexible, and preferably balanced steroids over saline, depending on the socioeconomic status of the country where you are. How much fluid to give should be determined by dynamic parameters rather than static parameters. If you give a large volume of fluid, which was not specified how much is large, then albumin should be supplemented. Gelatins, don't give gelatins in sepsis and septic shock. Lactate levels, you should monitor it, but that should not be the guiding principle. And capillary refill time, which is it costs nothing, but grossly underused all over the world, should be used more. MAP goal, mean arterial pressure goal, should be more than 65 millimeters of mercury, and within 6 hours, you should admit the patient to the ICU. So, next 20-25 minutes, this is what I'm going to discuss. Surviving Sepsis Guidelines 2021. What about the fluid resuscitation updates? I'm going to put some spanner in the standard guidelines. What are the AKI guidelines for dialysis? Vitamin C, there are 2 trials I'll discuss, and so on. This is one of our own patients on ECMO. As you can see, there are multiple drugs going. There's a ventilator, the drugs, pretty sick patient. Okay. So there was now conventionally, restrictive fluid therapy is what is recommended in septic shock because too much of fluid can harm the patient. So liberal versus restrictive is what discussion has been going on. So this is a recent study, 2022, and here it was a stratified parallel group, open label, international RCT, and they concluded that it made no difference whether you give liberal fluid therapy or so. But there were a lot of weaknesses in the study. It was unblinded. The most common infection source was GI, which is not commonly done in the ICU. And the difference between the two groups was only 800 mils. So that really will not be able to show any significant difference. Then this was a paper published in NEJM 2023, supported by National Heart, Lung and Blood Institute, early restricted versus liberal fluid management for sepsis-induced hypotension. Again, among the patients with sepsis-induced hypotension, the restrictive fluid strategy did not result in significantly lower or higher mortality. Again, what were the weaknesses? It was an unblinded study, although it was randomized. It was a single country study. The study was stopped earlier. Patients were not very sick, and no dynamic methods for fluid resuscitation to assess the fluid responsiveness were done. And this was a paper from Brazil. Levia Mercado was the second author. Uh, and Brazil is similar to our developing countries in terms of socioeconomic status. So they compared a large study, multi-center, normal saline with the balanced salt solutions, because balanced salt solutions are a little more expensive than normal saline. And their conclusion was it did not significantly reduce 90-day mortality. But there were a lot of weaknesses in the study. Although it was a large, multi-center, randomized trial, but there was no intention to treat studied. Mortality was lower than expected. Patients were not that sick, as demonstrated by low SOFA and Apache scores. And medium volume of trial fluid administrators were low, and there was a crossover between the two fluids which were being studied. So it is really, again, equivocal conclusion. This was another paper in NEJM in 2022. And what they double-blind parallel group randomized control trial, they studied acute kidney injury. So no evidence that the risk of death or acute kidney injury among critically ill patients in the ICU was lower with the use of balanced salt solution. Again, see, this is, we have to take it with a pinch of salt, because recruitment size was not very big. Fluids were not controlled or recorded outside of ICU. So the study stopped once the patient left the ICU. And alternate fluid may have been given to some of the patients, although it was a large randomized controlled trial. But I would like to point at this point of time, normal saline is not normal saline. It is abnormal saline. It contains 154 millimoles of per liter of sodium and same amount of chloride, which are both very high. So if you give too much of this fluid, there is hyperchloremic acidosis. Okay, so there is no denying the fact. And if you look at the balanced salt solutions, although the prices have come down, the Ringer's lactate solution is much cheaper than the standard balanced crystalloids, and therefore that may be a better option than normal saline. Then we talk a lot about septic patients who are, you check the fluid responsiveness and only then give the fluid if the patient is fluid responsive. So in this particular study, there was no significant difference in mortality between septic patients resuscitated with a volume responsiveness guided approach compared with standard resuscitation strategies. Because many of the countries may not have, only tertiary care hospitals have dynamic measurement possible of fluid responsiveness. So that is what, but there are many caveats in this study, too much of heterogeneity, and so on. So this is a little bit confusing. So where do we stand now? The Surviving Sepsis 21 guidelines recommended early administration of 30 mils per kilo of fluids for sepsis-related hypotension, or if the lactate is more than 4 millimoles. This is a weak recommendation with low quality of life. And fluid administration after initial resuscitation should be guided by careful assessment. So I think dynamic measurements are still recommended in a later stage. So there is increased focus, all these studies which are showed, increased focus on tailoring resuscitation to the individual patient by administering IV fluids more judiciously after the initial resuscitation. So this was a meta-analysis, balanced crystalloid versus standard normal saline. And if you pool all these together, there is slight inclination towards balanced solution. And in a subgroup analysis, balanced solutions were a bit better from the point of view of AKI, sicker patients. So if a patient is very sick and if you do not have too much of economic constraints, balanced solution still makes sense because it's more physiological than abnormal saline. Now coming to there was a lot of discussion which has been going on, early versus late dialysis. And it makes no difference, that's what was said. But in this particular study, they did two delayed strategies. So in severe AKI, they said that delaying the dialysis does not help. In fact, it may be detrimental. So if the patient needs dialysis, then there is no point of waiting for dialysis, hoping that kidneys will improve. And this was a Scandinavian paper, blood pressure targets in comatose survivors, because there was some discussion about higher pressures for better perfusion of the brain. So here they compared 77 millimeter with 63 millimeters post resuscitation, and they found no significant difference. In fact, at a higher pressure, there were more cardiac side effects because the afterload is increased, the heart rate will be increased, coronary perfusion can be compromised. So I think at the moment where we stand is 65 millimeters is what we should target. And this was a famous paper. Now, we used lots and lots of vitamin C during the COVID crisis. So this was Anand and Vijay Raghavan from Australia. So they did the study on IV vitamin C. So they concluded in adults with sepsis receiving vasopressor therapy, the ICU, those who received IV vitamin C had a higher risk of death or persistent organ dysfunction at 28 days. So this is a negative study that they do not recommend usage of vitamin C. And this was another VICTUS trial. They compared the HAT therapy, that means thiamine, hydrocortisone, and ascorbic acid. And again, they found no difference between the vasopressor-free days and ventilator-free days, and so on. So at the moment where we stand is vitamin C has really no significant role in sepsis and septic shock patients. Now, most of these patients, many of these patients, particularly those on the ventilator, would be sedated, and therefore propofol is the commonest agent being used because benzodiazepines like midazolam, they lead to higher incidence of delirious ICU psychosis. So this was a study which compared dexmedetomidine, which is a newer alpha-2 blocker, against propofol for sedation in mechanically ventilated patients. Normally at my center, we use dex when we are ready to wean the patient because patient does not get agitated and makes it easier to wean. But in this particular study, they found no difference in the outcomes when they compared propofol with dexmedetomidine. But again, for the people who have not used dex is a good drug, but it has some negative inotropic effect. So blood pressure does drop with some degree of vasodilatation, and bradycardia. So I think one has to keep that in mind. Coming to my own country, and this is applicable to many of the neighboring countries, what are the challenges in this country? If you see, blue is where the incidence of AMR is high, sepsis is high. You see, all these countries is blue. Dark blue is even higher, but dark blue is only in sub-Saharan Africa and Western Africa. So our incidence in Asia is pretty high. So this was an Indian paper, which we published just recently, 24. And this is a large study, more than 1,000 patients we studied who met the sepsis 3 definition. It's a purely Indian study over a large number of ICUs, 19 ICUs, private as well as public hospitals. And we found about 65% were gram-negative sepsis. And the rest were gram-negative, gram-positive. Acinetobacter was 11%, Klebsiella was 35%. Klebsiella is a rising threat in India, and I'm sure it's in the neighboring countries also. Tropical infections were not very high, and the mortality in septic shock was higher, 50%, but in sepsis was 25%, which is comparable to the Western data. So what are the challenges which we are facing in this country? Well, infrastructure. Tertiary care hospitals, private ones are very good. Public hospitals are overcrowded, undermanned, under-equipped. Antimicrobial resistance is a rising challenge with high incidence not only of sepsis, but AMR. Changing demography, shortage of doctors and trained nurses, socioeconomic issues. Patients come late, so poorer prognosis and delayed diagnosis and treatment. So this was a paper in ICU care in India. Challenges, beds are only in India 0.5 per 1,000 people, which is hugely insufficient. And most of these patients, 12 states comprise 70% of India's population. So most of the people are not adequately covered by ICU or hospital beds as well as ICU beds. The number of training positions are insufficient. For 1.4 billion people, we have only about 1 million doctors, out of which only 20,000 are trained in critical care. And the number of seats are insufficient. It's about 250 per year whom we train in critical care. So you can imagine how much the shortage would be. So this was a famous paper by Gandra, retrospective 10 hospital study, and they found that if you had MDR or XDR, then the 2 to 3 times mortality was higher. We have this INI group, International Nosocomial Infection Consortium. I've been actively involved for several decades, and you can see what is the incidence of hospital-acquired infections. In France, it's 4.4%, Italy 6.7%, Germany 3.6%, India it is 17.4%, Malaysia 14%, hugely much higher. And then again, this was a study in 55 ICUs, old paper, 55 ICUs in the developing countries. We pooled the data and huge number of patients over a period of 4 years. And as you can see, incidence of VAP, ventilator-associated pneumonia, was 24 per 1,000 device days. It is less than 1 in the Western countries. Catheter-related bloodstream infections, central line-associated bloodstream infections was 12.5. Again, it's supposed to be less than 1 per 1,000 in Western countries. And COTI, catheter-associated urinary tract infection, again, much higher than the Western countries. So then the question arose after when we published this paper that what about India specific? Because this was a pooled data of all developing countries. So we pooled the data. We published this paper again in 8 Indian cities. And again, we found incidence not only was much higher, but it doubled. Once you got a bloodstream infection, the length of stay doubled and mortality significantly increased. This was a paper, again, a large data, Western as well as Asian data pooled together, published in JAMA. Chaulu Ivasa was the first author. I was also one of the authors. And we concluded out of all this data, from all over the world, that if once you got ICU-acquired infections, the odds ratio of mortality was 1.3. So significant contribution to mortality. What is the main problem in India particularly? The diagnosis gets delayed because laboratories do not have adequate computerization, although it is improving. And the cost of healthcare in India, particularly private healthcare, still is huge, 100,000, 50,000 to 100,000 rupees per day, which is, and the per capita income in 2017 was 110,000 per year. So I think there's hugely burden on the socioeconomic status because still most of the patients are not health insured. There are certain research challenges. Not much of research is coming out, although this is also getting better because there's shortage of experienced staff, there's not enough motivation, GCP compliant trial sites are limited, sponsors are required, so there's a shortage of money. Some states there is a political instability, so they are not interested in research. There are some cultural issues in some parts of the world, and so on and so forth. So where do we come? Despite progress in sepsis management, as you can see, the cumulative mortality still remains very high in septic shock and severe sepsis. So where do we go from here? This is the standard treatment, survival versus treatment, and so you need to pull the graph from here to here. So if the conventional therapies are not working, you need to think about some novel interventions. So let me just cover in the next few minutes some novel interventions developed in this part of the world. Well, ulinastatin is a urinary trypsin inhibitor, serine protein inhibitor. It's present in human urine, and molecular weight is 62 to 72 kilodaltons. So this was a randomized control trial. The molecule was developed in Japan and China. And there are a lot of publications from there. But this was a paper which was a randomized control, large trial in, I think, western part of the world. And Dilip Karnad was the first author. And they found there was a ulinastatin group had lower incidence of new onset organ failure, more ventilator days, shorter hospital stay, and significantly less, 3% mortality versus the control, which is 20.3%. So this was a positive paper, although there were a lot of flaws which were discussed later on in this study, but it was a randomized control multi-center study. And this was a paper which we published many years back. We did a retrospective analysis of 134 patients in whom we gave the drug. 67, we gave the drug, 67 received antibiotics, standard of care, did not receive ulinastatin. We found a 24% reduction in mortality, significant reduction in duration of vasopressor requirement and ICU stay, significant improvement in SOFA score, and significant improvement in creatinine, serum creatinine. Then there is a lot of discussion about heme adsorption. This is one of our own patients. So these are not filters, by the way. These are not hemofilters. These are heme adsorbers. So they realign the balance between the pro and anti-inflammatory cytokines. So they absorb all molecules between 5 to 65 kilodaltons. I have a lot of experience in that. This was the first paper of mine of 100 patients with heme adsorption, which is cytosorb. And we found significant reduction in all markers: procalcitonin, CRP, serum lactate, serum bilirubin, with the use of therapy. Also, interleukin 6 and interleukin 10 and TNF all is significant. We found a significant reduction, fall in the severity scores, and also predicted mortality was better. Significant reduction in vasopressor requirement. So this was a positive study. And we also found in that particular study that if we used it within 48 hours, the mortality was 30% compared to 70% when we used it after 48 hours. So earlier use is better. Then came all of us have gone through that hell of COVID-19. Okay? So this was our first paper published at that time, because cytokine storm plays an important role in COVID management and COVID outcome. And this was the first Italian patients who were admitted in India, in the Indian ICU, which we had managed them. And out of 16 patients who were admitted, all were over 70. Only one patient died. She had a malignancy. Rest all went home. So these were the day they were discharged from the hospital, and you can see how happy they were. So this study I did it with the Indian Council of Medical Research, and this was highly publicized at that time. So based on these, we decided to do a randomized control trial. Tocilizumab, which was used quite commonly. So we did this randomized control double-blinded trial of tocilizumab in the cytokine release syndrome. And again, in the pooled analysis, we did not find any significant difference, but in subgroup analysis, we found it to be useful in severe COVID-19. Then there is a new molecule, Mycobacterium W. It's a non-pathogenic mycobacterium. It is generates strong T helper cell response, suppresses the cytokine, so poly-TLR antagonistic activity, activates the macrophages, T cell proliferation, and genetic expression modulation. And it does attenuate the sepsis response with faster killing of organisms. But one problem with this molecule was that it was given 3 intradermal injections. So that was a little painful for the patients. So we published this paper in Lung India. We gave it IV, 0.6 ml, and there was no problem. So now we started routinely using IV. Then you talk about dynamic response to check the fluid responsiveness of the patient. And some of the dynamic response measurements are quite expensive to use. So particularly in the developing countries. So this was a paper by Sheila Nayan Mehta and Jean-Louis Taboul, also was a member, Javier Monet. These are all big names in hemodynamic management in sepsis. So what they did was, in this particular study, patients already on ventilator, they gave a tidal volume challenge. So they increase the tidal volume from 6 ml per kilo to 8 ml per kilo to 10 ml per kilo, and then reduce it in graded this thing. And they saw the changes in PPV and SVV, and they found this corroborated very well with fluid responsiveness. And this is a cheap methodology. You're not taking off the PEEP also. So I think this works quite well. Then certain new antibiotics have come out of India, and this was a levoleucidophloxacin, which is also available orally and IV. And we published this paper, and it's very good, effective against all gram-positive bugs and certain anaerobic bugs also, including effectiveness against MRSA. So we found it a very useful one. I use it quite a bit. And thymosin alpha is another immunomodulator. A lot of papers from China and a lot of positive papers. If you see most of the papers of ulinistatin, they have used it along with thymosin alpha. So Indian Council of Medical Research is now participating a lot in improving the healthcare in India. They're coming out with a lot of data, a lot of guidelines and recommendations. So it's playing an important role in India. So what are the potentials for future management? Early prediction and diagnosis of sepsis is very important. Better categorization of disease stage, the phenotype, better drug delivery methods, and fewer antibiotics. So early prediction and diagnosis, AI is going to play an important role. Nanotechnology-based diagnostics are coming, and use of combination of panels for biomarkers. Precision medicine is where we all are heading. Every patient is different. You need to put them into a correct phenotype, and then you decide which medication or how to give. The standard of care will be changed accordingly. So antimicrobial stewardship plays an important role. Particularly, misuse of antibiotics is very common in this part of the world. Prediction of organ dysfunction, then with early markers of AKI, allocation of hospital resources, diagnosis, and severity become important. So thank you very much for your attention, and I'm quite happy to answer any questions.
Thank you, Dr. Jatin. Dr. Yatin Mehta, thank you so much. I think we can just close the presentation so that we can just see the screens. Dr. Chong, would you like to take it over?
Thank you, Dr. Mehta, for your interesting presentation on sepsis management. I just have a question to ask. I also remember that recently there's been a lot of talk about IV thiamine in ICU care. And I also like the fact that you highlighted IV albumin. One of my favorite tricks is to always try to push the albumin level of my patients who are in hospital, obviously, low albumin, to about 4 grams per liter. Any thoughts on thiamine and albumin? Thank you.
See, regarding thiamine, yes, there have been a few papers which have shown thiamine deficiency in patients in the ICU. But the HAT paper which I showed was a negative paper, although that was a combination of 3 drugs. So yes, if the thiamine levels are low, if the patient has CLD and so on, which are likely to lead to thiamine deficiency, thiamine may help. Another thing which is coming up is vitamin D. A significant number of patients in the ICU are vitamin D deficient. So I think it is a good idea now to start measuring them at least, and then give the replacement if necessary. Regarding albumin, yes, I've been to Singapore many times. I know you do not have any financial constraints there, but yes, that is a consideration. And this little hesitant recommendation for albumin was put in the surviving sepsis guidelines, considering the socio-economic status of the whole world. So there are constraints there. But yes, if there are no constraints, albumin should be maintained at a higher than 3 at least. 3 is the normal cutoff, particularly if the patient is malnourished. Although nourishment status is not guided by albumin levels, that which is the recommendation of SMID and all the other bodies. But yes, if the patient is giving too much of fluid, or if the patient is hypotensive, or if the patient is hypoalbuminemic, it's a good idea to replace that.
I find sometimes I found some, okay, not my ICU patients, but sometimes I've been asked to see, some ICU patients by relatives or something informally.
Yeah.
And I find there's actually a lot of fluid overload. I find that especially older patients, we have quite a lot of elderly patients in Singapore, the aging problem, And I find that actually fluid management in elderly is sometimes a little bit too cavalier, right? They overload the patient quite a bit. Or what are your thoughts?
Absolutely, I agree with you. Several papers have shown that positive fluid balance not only increases the mortality in the ICU, but also leads to more organ dysfunction.
Yes.
It is a misconception that more fluid will improve the kidney perfusion. It does not. In fact, it can be detrimental because of interstitial edema. And therefore, actually, I have started half the beds in my ICU now are weighing beds, where I can check after a couple of days the weight of the patient, which is checked every day. And it's a good idea because the fluid resuscitation, now they call it the ROSE therapy. That means resuscitation, optimization, and finally stabilization and de-escalation. So if patients with a lesser fluid balance, the negative fluid balance, do better than patients with a positive.
Do you yourself have a kind of guideline as to how much fluid positive balance your patients can bear? Do you have some kind of idea, or do you have some side?
No, there are no guidelines on this, but yes, a couple of liters patient may be able to tolerate, but more than that, particularly elderly patients or patients with cardiac comorbidities will not be able to handle after a few days.
Yeah, I actually have noticed that is quite a lot of fluid overload, especially our elderly patients. Yeah. Thank you. You've answered all my questions brilliantly.
A couple of questions.
Thank you.
In case of complications where sepsis has created a complications, what is the chances of it to come back in case it is fully treated, and can it be fully treated?
I can see that question is coming from a non-medical person, but yes.
So I had a lot of struggle journey with my dad. So I think I am not a doctor, but yeah, I have seen this part.
No, but I can see what happens is that initially they may improve, but many of them, if they stay for too long in the ICU or in the hospital, they get a secondary sepsis.
Yeah.
So that has to be. Also, nothing is going to work unless you do the source control. So if your antibiotics are not working after a few days, you start thinking in terms of a secondary other source of infection. That means you do radiological investigations and so on to find out from where the sepsis is coming. And after a few days more, still persisting, start thinking in terms of fungal sepsis. Because see, many of these patients would be on steroids, they may be diabetics, so they may be prone to fungal sepsis also. So if the patient is not getting better after a few days of antimicrobial therapy, start thinking.
Dr. Mehta, can I ask you, what is your take? I found some of my infectious disease colleagues are over the top. They keep throwing antibiotics of all kinds at the patient. I don't know. It seems like there is no strategy. At times I find my ID colleagues, I don't know what they're doing. I make sure I have good ID guys that I find they have principles. But a lot of them sometimes they're just throwing darts at the board. And what are your thoughts?
See, Dr. Bukhari here is an ID guy, so I'll be a bit restrained in my comment. But yes, see, their theoretical knowledge is very good. The ID guys, they know more than me.
Yes.
but they sometimes do not look at the patient holistically.
Yes.
So they'll be just focused on the cultures and they'll just focused on the antimicrobials, but they will not look at the whole patient. Also, we need to de-escalate. I hate using too many unnecessary antibiotics.
Yeah.
So I think if the cultures have grown something, or if there is a particular indication on molecular testing that the patient has this sort of bugs and these sort of enzymes which are likely to damage the antibiotics, then I'll change my antimicrobials accordingly and then cut down the rest which are unnecessary. Also, there is excessive use of antifungals. These are expensive drugs.
Yeah.
Unless the patient is immunocompromised, one should not shoot with all the guns.
Yeah.
Can I add something, sir?
Yes, Dr. Bukhari. Yes.
Please.
Thank you very much, Dr. Mehta, Yatin Mehta. Thank you very much. Very nice topics. And because from the last 2 days, I am here in the conference of infectious diseases. As a pathologist, I will appreciate that. No doubt you are an anesthesiologist, but you have covered a lot of things regarding the basic things that we learned during the COVID was the cytokine storm. And I'm very pleased to see that you have also established a paper on it. There are so many papers established. Actually, I was astonished to hear, even read that there are certain things that we should not use, like steroids or vitamin C or thiamine. But sir, my question to you, sir, why they used steroid during the cytokine storm to stop the cytokine storm? I think it was not cytokine storm, it was the vasodestruction that was saved by the steroids. Why they used it and how it was effective during the that COVID time?
See, for COVID-19, steroids are still recommended.
Yes.
So I think that is the standard of therapy. There's a large study, British study, which was a multi-center study, which established the benefit of steroids. But yes, there was certain standardized dose which had to be used. Do not exceed the doses, because if you give too high doses, like sometimes in the developing countries, I found they gave 30 milligram per kilo of methyl prednisolone, and that will certainly lead the patient to have a secondary either bacterial or fungal sepsis. So a lot of patients died during COVID because of secondary sepsis.
Thank you, sir. Another thing was that, sir, before that we treat the sepsis, and it is very important that prevent the patient going in the septic, because the septic or the septic shock, as the Dr. Chong was saying, is not only due to the bacteria, but it can be due to fungus, it can be due to parasite, it can be due to viruses. So the basic important thing that in India and Pakistan, due to population, due to poverty, due to publics, it is very, very important to prevent the patients to going.
Absolutely.
We should prevent the factor. We should concentrate on the factors like you described in a chart. There are antibiotic resistance, there is poverty, there is all things. So we should include in our parameters as a doctor for the governments or the private sectors that they should have certain criteria going the patient to how to prevent the patient going in the septic shock. Sir, another question to increase my knowledge was how should they reduce the toxins, because mostly this shock, the septic sepsis or septic shock, is due to toxins. What should we do other than this fluid or other than this antibiotic or something? What should we do to reduce the toxins like endotoxin or excess toxin shocks?
See, endotoxin are basically gram-negative toxins
Yes,
which
yes,
are
sir.
released
Yes,
from the
sir.
gut.
Yes, sir. Yes, sir.
So a certain heme absorber has been used, Torre filter, although the recommendation was against Torre, but it does reduce the endotoxins. But yes, if you cannot use it blindly, it's an expensive modality. You need to measure the endotoxin levels, and If it is more than 0.9, only then it is going to be effective. Less than 0.9, it's not going to be effective. So I don't waste your resources on that. For gram-positive sepsis, staphylococcal exotoxins, the cytosol absorber also has been used. Also, some people do use immunoglobulins, but again, the evidence is a little mixed, so I can't really say. But yes, if you're in a corner, you may use them.
Thank you, sir. Thank you so much, sir. Thank you. Nice topic. Thank you, Saurabh. And one question, one answer to Mr. Saurabh. You are doctor of doctor. Actually,
I don't think I am privileged to
the
get
early diagnosis and early management, any type of this can save the life of the patient.
Absolutely.
Sir, in fact, I would be very, I would like to make a point that home management of any disease is very, very important. Whether you're a doctor or a non-doctor, I think a very presence of mind, and if you are able to diagnose things in advance, I think a lot of doctors can get a support. Otherwise, even if you're good at last stage or probably at a mid stage, even doctors have a very limitation. But if you can do a home management, and if you can be very smart enough to contact a doctor at the time when it's really important, is very, very crucial stage, what we say.
So thank you, Saurabh. I think I'll now
Yes, sir.
work.
Thank you. Thank you, Dr. Mehta. Thank you very much.
Thank you, Dr. Mehta. I think it was very, very
Thank
encouraging
you.
for us to have you here.
Pleasure.
Yeah, thank you. And we hope to see you again soon. Thank you very much.
Thank you.